I did training as a physician, anaesthetist, intensive care and a PhD in surgery, and started at Prince Charles and became director here at St Andrews in 2012, I think.
After 6 years of extensive preclinical trials devised by Professor John Fraser, the group recently helped secure a new world record with a heart being kept alive outside of the body for more than 7 hours before transplantation. This game-changing research also laid the foundations for the historic pig heart transplant performed in Maryland, USA in January 2022.
St Andrews is probably one of the biggest private cardiac hospitals in Australia, and in our group, the Critical Care Research Group, we've worked on cardiac medicine because it's the biggest killer, whether it's public or private, it's the biggest killer and it's becoming more of a problem. So we work in all fields of cardiac medicine, preclinical and also clinical. In the preclinical field, with Dr. Daniel Timms, we developed a total artificial heart called Bivacor. It's about the size of a fist and it requires no heart tissue at all. But also we are working, in fact, this afternoon, as we speak, we're doing a transplant on an animal, and we've done this for 4 years, and we've now transplanted 35 people that would have never been transplanted using an innovation of a rig to keep the heart alive for longer, so that across Australia, this vast brown land, the tyranny of distance is important, but now we can transplant anywhere in Australia.
So I came to Australia about 8 years ago to do my PhD and finished it in the liquid biopsy space, and we sort of got into spatially mapping the tumour microenvironment. So it's really using this Google Maps approach, which I've led in the Asia Pacific region over the last couple of years, and that's where my lab's really focused on at the moment.
As the world started to see a strange new virus, the Critical Care Research Group did not sit idly by. They recognised the once-in-a-lifetime opportunity to capture data to support ICUs at the front line of treating this unknown disease. And so the COVID-19 Critical Care Consortium was born. 2 years and 250,000 hours of data entry later, the consortium has assembled 35 million data points with the assistance of 380 hospitals in 54 countries.
So I'm fortunate to be the president of the whole Asia Pacific region of artificial hearts and lungs. And in January 2020, we had a young doctor from Wuhan in our lab, and he told us about this funny virus. And then we started getting calls from our colleagues across China initially, asking us for help on how to ventilate these patients. We didn't really know, but it became apparent that it was going to grow and grow and grow. And we in Queensland were very fortunate. We had none of the virus, but we felt we had a moral responsibility to try and help. People were communicating on WhatsApp. Vast amounts of data, but it wasn't connecting, so it was like 1 million jigsaw puzzle pieces scattered, and we couldn't see a picture. But the feeling was if we brought the jigsaw puzzle pieces together, we could start to identify things, and that's what we did. So we now are working in 7 continents, 64 countries, have got more COVID data than anywhere else in the world.
So it's a blessing, I think, that happened in COVID-19. So I reached out, we had these samples from clinicians in Brazil. They had the lungs, the hearts, and then brain tissues from COVID-19 patients taken at autopsy. Reached out to John and said, John, look, we've got this incredible resource here, which in Australia we didn't have the caseload at the time. Could we work with you and some of the consortium and really engage with these samples? So we mapped these tissues cell by cell, so really localizing, looking at where the virus was in the lungs, in the heart, and the brain tissues, and we found some really, really exciting findings from them. So the study that the Wesley funded us, John and I, for the COVID-19 Neuro Project, we looked at 10 brain samples. So we were given 10 samples. We didn't know which ones were normal, which ones were from COVID patients, and we ran the assay on these samples, and we could identify that 5 of them clustered together. And so that was a really interesting finding that we saw early on. And we went back and when we looked at the data, they appeared to show DNA fingerprints of COVID-19. So we went back to the pathologist and said, are these the 5 samples that are from the COVID-19 patients and not these 5? And indeed, those were in fact the COVID-19 samples. So it shows you how, using these technologies, we can now identify very clearly the impact of COVID to these organs, but really understand the underlying biology.
So what we saw was that people were starting to wake up confused. There was a fog, the COVID fog people talked about, and we saw in intensive care that there was an increased rate of stroke, and we didn't know why. So we wrote a grant with Arutha to the Wesley to actually understand what was changing within the brain tissue. The study isn't finished just now, but we've managed to get samples from an international collaboration from Brazil, from the States, from other places, so that we see it's not just a country-specific thing. So we're answering a question that the whole world wants to find out, and it's been answered right here through ourselves and the generosity of the Wesley and St Andrews. Again, very fortunate, Arutha is one of the world leaders, and we've got these samples from around the world, and the question is the key part. Actually, the machine is amazing, but to actually use it is not so difficult, but we don't have one in Australia. So we're leading the world, but without the technology. It's like being the best Formula 1 driver, but we don't have a car. So we're sending samples, they come to here to Australia, then we send them back to America, who do some of the work for us, and then we do a lot of what's called bioinformatics, which is a huge job on its own. But yes, we want to be the first in Australia. We want to have the best for our patients, and we want to lead the world. So this essentially gives us the power of 200 pathologists looking at the same piece of data. There's many, many fields we'll be able to use it in. Clearly cancer is a huge field, and it's an area of Arutha's expertise. 3 out of 4 people chemotherapy might not work for, and this technology will be able to tell us. But the same from my own field, intensive care, cardiac medicine. Cardiac is the biggest killer, beats all cancers. We are good at cardiac medicine at St Andrews and the Wesley, we are outstanding. But we can learn more, we can diagnose quicker, we know what treatments work better, and that gives you a brighter tomorrow. And again, lung disease, acute respiratory distress syndrome is one of the biggest killers in intensive care. We lead the world in some of this work, but having this additional tool will just put us at laser speed.